All right, it is 1 o'clock, so we will get started. Good afternoon, everyone. My name is Chao Wen, and I'm joined today with my education co-chair, Denise Parr. We would like to welcome you to the APIC Great Lakes 2024 Educational Webinar Series. So this month's topic is webinars, poster presentations from National APIC 2024. In addition to this, we will have 2 board members share their conference learnings and takeaways. To ensure that we can all benefit from this webinar, please keep your line on mute and not hold. So hold may play a message or music disrupting the webinar. And as Denise dropped in the meeting chat, if you have a question, please drop it in the chat so that we may ensure your question is brought forward during the Q&A portion of the webinar. For today's presentation, there are no CEUs available. And we are also excited to announce that the MDHHS HAI section recently partnered with the Michigan Health and Hospital Association Keystone Center to create a comprehensive infection prevention and control learning program to support continuous learning in healthcare settings. So the series includes 6 courses designed to integrate into an organization's comprehensive infection prevention and control training plans. Participants will receive a certificate of completion for each course, which can be retained for employee training files. Additionally, there's also a new micro lesson on our YouTube channel created by our very own Rebecca Badges. This will help you to navigate between the APIC website and APIC Connect, where the discussion boards are, show you how to update your email settings on the APIC community site so you get real-time announcements, and teach you how to engage in the online discussion boards. If this is something you could use as a refresher on, or you are interested in learning about, please watch the 7-minute video that is available on our YouTube channel. It is very helpful, so please take a look. And then I'm also very excited to share that following today's presentation will be the very first peer-to-peer mentorship roundtable discussion led by our board members, Dorine, Berriel-Cass, and Jenny Madigan. And with that, I will introduce all of our speakers before I hand over the floor to them today. Our first board member is Nicole Nomides. So Nicole is currently Director of Infection Prevention and Control at Ascension of Michigan, and has been working as an IP for 20 years with experience covering all levels of patient care. Nicole has served as a board member for the APIC Great Lakes chapter, including various elected positions, and received the Chapter Leadership Award in 2013. Nicole is currently the 2024 APIC Great Lakes President and has served on the National APIC Nominating and Awards Committee and Membership Services Committee. She has also presented multiple oral and poster presentations at numerous chapter and national APIC events. Our second board member presentation will be from Dorine Berriel-Cass. Dorine is currently an infection prevention consultant. She has passionately worked in infection prevention and control for over 33 years, recently retiring from her position as System Director for Infection Prevention at Corewell Health in Grand Rapids. Dorine is currently the President-elect for APIC Great Lakes. She also served on the National APIC Board of Directors from 2019 to 2021. Dorine is certified in infection control and is a fellow of APIC. And then our first member presentation will come from Jim Codman. Jim has been an infection preventionist for over 12 years with experience in long-term care, long-term acute care, ambulatory, and hospital settings. His area of focus now include CLABSI prevention and in specialty populations such as burn, ICU, and oncology. He began his career in healthcare as a nurse tech and then worked as a bedside nurse, nursing unit supervisor, and quality manager. He remains inspired by the dedication of everyone caring for patients and their families in these challenging times. Our second member presentation will be Tamika Anderson-Mays. Tamika is an infection preventionist at Ascension St. John's Hospital in Detroit, Michigan. She started as a medical technologist at Ascension St. John Hospital in 2006. In 2007, she received her American Society for Clinical Pathology certification. In 2015, she received her Master's of Public Health from Oakland University. She began her career in infection prevention and control in 2018. Her areas of focus include the neonatal intensive care unit and women's and children's. In 2021, Tamika obtained her certification in infection control. Our third member presentation will come from Alex Wells. Alex is a manager of safety and reliability with a focus in infection prevention at Henry Ford West Bloomfield Hospital in Metro Detroit area. She has been in the field of infection prevention since 2019 and obtained her certification in infection control in 2021. Her focus areas include prevention of device-associated infections, high-level disinfection and sterilization, and process improvement. Our fourth presentation will come from Jennifer Madigan. Jennifer is the lead infection preventionist at Ascension St. John's Hospital in Detroit, Michigan, and Ascension River District Hospital in East China, Michigan. Jennifer earned her BS in biology and MPH in hospital and molecular epidemiology at the University of Michigan School of Public Health. She first received her certification in infection control in 2022. Jenny is an active member of APIC Great Lakes and currently serves as the bylaws chair. And our last but not least presenter is Christine White. So Christine is a dual board certified infection preventionist on the Infection Prevention Resource and Assessment Team at the Michigan Department of Health and Human Services. She received her master's in public health with a certificate in epidemiology in 2019. She has experience practicing in various congregate care settings, including long-term care, acute, behavioral health, ambulatory clinics, jails, and correctional facilities. She specializes in infection prevention and accreditation, education, and guidance. When not spreading the good word about the importance of practicing strong infection prevention practices, she enjoys devouring books, camping, paddleboarding, hiking, sewing, and crafting. And with that, I will hand the floor over to our first presenter, Nicole.
Thanks, Chow. So these are obviously not my slides, but I was really lucky to get to attend this presentation of APIC summarizing some of their strategies to help grow and develop our profession. So just a little summary. Next slide. So we all know how complex our jobs are as infection preventionists and all the things that need to go into development of a good, strong, successful IP from, education and training and experience, but also, mentorship and job satisfaction and the importance of a work-life balance. There's been a lot of burnout in the last few years. So I think it was really nice that APIC has acknowledged, the complexity of, the needs of a successful IP and taking all of that into consideration as they're providing support for infection preventionists. Next slide. So they basically shared the 4 strategies that they're working on at APIC for development of IPs. And that's the IP Career Development and Advancement Guide, a new plan for an IP academic pathway, a new plan for an IP apprenticeship program, and updates on the IP staffing calculator. Next slide. So if you haven't seen this before, APIC has this really awesome tool available to all infection preventionists, available to any APIC member. You can download this guide right from the APIC website, and that's the Career Development and Advancement Guide. It's pretty comprehensive and offers support for recruitment, retention, and promotion of IPs within your IP program, the framework for implementing the APIC IP competency model, and just provides some guidance for anyone who's interested in entering the field of infection prevention and what's possible and how to get there. I think it's a really great tool that can be used really for any level of infection preventionists, from a novice to a seasoned IP, for leadership, and even for organizations. So if you haven't checked this out, I can actually drop the link to the document right in the chat afterwards, if that's okay, Chow. If you want me to do that, I can do that after. Next slide. And then something new that APIC's been working on that I think this is really cool, really exciting, is the IP academic pathway. So we all know that you can't go to school and get a degree in infection prevention. We're all, nurses or med techs or, public health professionals or all the other variety of backgrounds that we have. And we basically learn how to be IPs on the job. So APIC is working to develop curricula for actual degrees in infection prevention, a bachelor's, a master's, and even a PhD program. They've been performing academic and professional surveys, looking at existing programs, and are really working to finish this up and have it available by the end of the year. So we'll be hearing more about where the programs will be available, what schools will be offering it. And, you know, I think this is a really innovative and new thing to the world of infection prevention. I think you can actually get a degree in IP. I think it sounds really cool, the idea of, you know, a high school student going to their guidance counselor and saying, I want to be an IP when I grow up. And they can say, well, these schools offer the program for you to go to. So this is really exciting. So we'll be hearing more about that in the coming year. Next slide. Another really cool thing is that APIC is working with the Department of Labor to create a licensed apprenticeship program. They're working with this organization, the Urban Institute, which is a research institute, to develop this program it's an earn and learn program. So it's pretty similar to what the skilled trades do. So individuals would enter a one-year paid apprenticeship, and there they would have on-the-job learning, some classroom coursework, IP mentorship and teaching, and really have that solid base to enter the field of infection prevention after this year-long apprenticeship. More details on the program are available at that QR code that I included in the slide. But again, we should be hearing more about this program, where it's going to be available in the coming year. Also very exciting. Next slide. And then the last thing that was shared were just some updates on the IP staffing calculator. So if you remember, APIC released an IP staffing calculator last December. This was considered to be sort of the beta test version. And it's really something that, you know, we've needed for a long time. There's literature that provides basic information on recommendations for IP staffing based on the number of IPs per licensed patient beds. But the problem is, you know, that's based on survey information on what programs have and not necessarily what they need. So the idea behind the new IP staffing calculator is, you know, to include more details and more information that can really help to determine what your needs are for IP staffing. So say your institution, your facility has an ICU or a burn unit or a bone marrow transplant unit. You're going to have different staffing needs than another facility that may not have those, you know, high risk areas. So I think this is going to be something that will be really, really helpful as we go on. And this was the test version. And they did share, if you go to the next slide, they did share some stats based on what was learned from last year's survey. So these are the types of facilities that responded, mostly hospitals, some ambulatory, some long-term care. And then the next slide shows, this is basically showing that your perception of staffing lines up, you know, statistically significantly with what you should have. So if you think you're not staffed well, you're likely not staffed well. If you think you are staffed well, you're likely not. So doing a lot of sort of validation of the data that comes through. And then really interesting, I thought, was the next slide that shows the relationship of IP staffing directly with HAI rates. So if you are a facility that is understaffed for infection prevention, there's a significantly higher CLABSI and SSI rate at those institutions. So, I mean, not a huge shock to those of us who work in the field that, you know, we need the IPs to prevent those infections, but I think that's pretty interesting. And if you go to the next slide, they will be sharing a new version of the staffing calculator this coming December that's going to have even more details involved, more optimization involved. So they're going to stratify for hospital units within the hospital, unit type within the hospitals. There'll be a section for ambulatory surgery centers, LTACs. It's going to be more user-friendly with more capabilities to, you know, pull information. And so when that comes out, please, please, please try to fill out that staffing calculator if you can, because the more data that APIC can gather, the more, you know, they can strengthen the study, and then they can publish that. And then we can use that to bring to our C-suites to help, you know, support our IP programs even more. So I think this is all really exciting. It's really great to hear that APIC is thinking of the future, thinking of how to better support current IPs and, you know, the next generation of IPs. So I really like this talk. It was great. More to come in the next year, though. We'll be hearing more about these elements, these strategies in the next year. Thank you.
And I will be next on board. Yeah, so if we I just wanted to share all of the picture of the APIC Great Lakes group that was at National. Next slide. One of the first meetings that I went with Nicole to the chapter leadership meeting. And this is where we were introduced to the idea of the chapter mentoring program, which is immediately following this program. But it's basically a pilot program that's going to give us an opportunity to support each other in our IP work. As Nicole mentioned about the staffing calculator, the APIC Research Center will be publishing staffing ratios for IP programs. They are working on that now. And when you have an opportunity to contribute information, please do. And then infection preventionist is officially listed as a job with the Department of Labor. So prior to that happening, it was a real identity crisis of who are you and do you belong here? Next slide. Wanted to call attention to Michigan's own James Moses. Dr. James Moses is the Chief Quality and Safety Officer for Corewell in Michigan, and he received the Healthcare Administrator of the Year award for his support for the Corewell IP program. But it was just a great honor to have an executive that truly promotes the work of the infection preventionist. Next slide. So one of the sessions I went to was the Practice Guidance Committee, and I'm kind of go through this fast, but I put a lot of information in the slides so that you can refer to them later. But basically, it's 4 subcommittees that are part of the Practice Committee. And they look at practice tools, business collaboration, implementation guides, and strategic communication. Next slide, please. So some of the practice tools that they're working on actually include long-term care and safe injection practices. And they're going to include their the pre-spiking of IV fluids, which I know we always have controversy with. And they just updated in the APIC news, there was a link to it, the MPOX playbook. They just updated it based on the new strain that they've seen in Africa and Sweden. Next slide, please. And these are just from the implementation guidelines committee. They're looking at the SHE compendiums and looking at creating concise, updated documents, which we all know we could use. Next slide. And that they also have liaison roles to stay engaged with organizations. So if you think about our AORN and AMI and ASHRAE and all these other organizations, when they're making guidelines, we want to have IP at the table and be a voice for our organization. Next slide, please. And this was just from SHE, some of the key updates that they have. And some of us that have been around for a while remember it could be a decade or more between updates on guidelines. So it's nice to see that these guidelines are being reviewed and updated on a more timely basis. Next slide, please. And then just a note here that World Health Organization is working on guidelines for prevention of bloodstream infections, but not just central lines, it's any intravascular catheter. And next slide. And this is just, previews of what's coming soon, and APIC News is great to update us on that. So just when that email comes with the APIC News, go ahead and take a look at it. Next slide. One of the other sessions I went to was on air quality risk assessment. And this was really fascinating because I don't know that we've actually always looked at this, but this Jennifer Ormsby and Cynthia Elwood created a risk assessment that they use. And this is after we've had several organizations publish outbreaks of fungus and related to healthcare or related to healthcare settings. But the first question on this tool is IP is not informed of planned air handling shutdown. So I don't know if you at your organization are or not, but that certainly is important for you to know that if an air handler is going to be down. Next slide. This goes on to say, looking at things like high horizontal surfaces contain dust or are visibly soiled. So again, we look at a lot of things within our environment, do we always consider the actual air when we're doing outbreak investigations? And next slide. And one of the feel-good speakers was Lisa Sun on choosing self-confidence, but she talked about believing in yourself and mentioning that our 5-year-old selves are extremely confident and can do anything. And then we get to the 11, 12-year-olds and all of a sudden we have self-doubt and we just kind of lose our confidence. And next slide, please. And this was just some of the APIC Great Lakes presenters that I had the opportunity to go to their sessions also. And thank you very much.
Jim, you're up next.
Okay, great. Thank you, Chow. So the project I'm going to present is titled Transmission of an NDM producing E. coli through a gastroscope from an EGD procedure. And I wanted to give call out to Brianne Bachman, who actually presented this oral description of our poster at the National APIC, if you happen to catch it there. So next slide. I have no disclosures to make. And next slide. I'm hoping as I go through this that you think about wherever you work to identify maybe potential sources of gastroscope contamination where you are, and then maybe think about what you would do if you had a similar outbreak situation, what you would add to what we've done at Corewell Health, and then just generally consider ways to decrease the risk of gastroscope contamination at your facility. Next slide. The background of our project was that the transmission of a multi-drug resistant bacteria like CRE has been, it's really been associated with duodenoscopes containing those elevator channels. However, published data on outbreaks associated with gastroscopes is definitely more uncommon. So our objective was to investigate the transmission of an NDM producing E. coli between 2 hospitalized patients to determine relatedness and potential sources of transmission, including a common gastroscope. Next slide. Before I do that, I just want to give a reminder about the difference between an endoscope, such as what you might use for an EGD procedure. So that endoscope, generally a simpler design, allowing the provider to look at the stomach, the esophagus, and the duodenum. As I said, few studies really document the risk of cross-transmission in those. And that's really in contrast to duodenoscopes, such as you might use for an ERCP procedure that has that complicated mechanism, that elevator that has some moving parts and some complicated design, which is harder to clean and disinfect. Next slide. The methods that we used in our project was really case study methodology, and we collected several data sets. The first one was probably the most time consuming, in that we needed to do a lot of chart review to determine possible links between our two cases in July through September of last year. We did whole genome sequencing. We also did some unit-wide point prevalence screening on 3 different hospital units. Had a very involved line list that we used to follow up with patients who had potential exposure and screening. We did some audits on endoscope cleaning and scope culturing, and then we also sent the scope to for inspection by a third party. Go to the next slide. I'm hoping this graphic gives a little clarity to the story, because it's a little convoluted. So the top part of this chart shows that we started with 2 patients. So patient A was admitted to the hospital on July 15th. So someone with some complex GI issues. They had an endoscope procedure on July 27th, were discharged on August 8th, and then we were made aware that they had a CRE, which was an NDM version from a culture that was done prior to that scope procedure. So we were made aware of that. And at the time, our hypothesis was that this patient had acquired that organism prior to hospital admission because they had some travel outside the country to India. So that sort of fit with, logically seemed to be a good explanation. The second patient, patient B, was admitted to the hospital. They had some complex cancer issues. They were admitted a little after the time period from patient A, and then also had an endoscope procedure shortly after patient A did. Our later follow-up showed that it was the same scope used for both patients. This person was discharged and then readmitted and then transferred on August 30th to a rehab facility. So while at that rehab facility, this patient had a urine culture, and we were later informed that that urine culture was positive for CRE-NDM. When we got that information, we started an investigation because initially this patient had no obvious risk factors. So we looked back in time, and I'm going to give you the end result right now and then some details. So we ended up doing whole genome sequencing on both those cultures and found that they were a match, which meant that there was a linkage between those 2 patients. So then our investigation was, how did that happen? What was the linkage there? This bottom of the chart shows an abbreviated timeline for some other patient exposure and scope follow-up that we did. It turns out that if you look at the time period between when patient A had their scope, which was July 27th, and when patient B had their scope, which was August 1st, there were a total of 9 patients who had used that same endoscope for a procedure. And then furthermore, if you look at the time period after that, but before the scope was sequestered, which is when we were made aware of patient B's culture results, there were 74 additional patients who used that scope. Also part of the follow-up that we did was we had sent in October, we had sent the scope for culturing, and then in November, we sent the scope out for a third-party inspection. So we were really interested in that group of 9 patients and then the 74 additional ones to see how widespread this issue was. And if you go to the next slide, as I said, what we found was that in that 5-day apart period, that group had the same scope used. We found that of those total of 83 patients on which the scope was used, we ended up doing a screening test for 45 of those patients who agreed to the screening. 33 people in that group either declined to have the screening done, and 6 patients had expired, and the review was that this was unrelated to CRE. So those screened patients were all screened negative. We also did a point prevalence screening on 3 inpatient units in which patient B was on before it was known that he had the CRE NDM. So on those 3 units, we screened 35 patients, and those all screened negative as well. We did a lot of validation of the cleaning and disinfection processes identified, and we didn't find any major breaches in practice. We also had, with some help, had the scope cultured and found that was negative. And then we also sent the scope to a third party for an inspection. And there were some findings that were interesting that I'll share in the next slide. So when they actually looked very carefully at the scope, the picture on the left is the inside of the scope. And you can see there's this wavy piece of, it looks like a piece of the inside of the scope that has been scraped, and that was damage to the biochannel internally. The middle picture shows, and this is, to my, at the time, less informed brain, eyes, really subtle finding. There was some damage to the outside of the coating of the tube that you can see by these indentations. I know it's a little bit hard to see in the photo. And then finally, the picture on the right shows that this glue band on the outside of the scope had what was described as some bending and opening. So if you can imagine, when the scope is bent, the edge of the band was able to open slightly, allowing contamination to get inside. And then if it's straightened out, that gap between the band and the scope closes, kind of trapping stuff in there, making the cleaning and disinfection more difficult. So if you go to the next slide, our conclusions were that, really the linkage that we found was the most likely was due to the whole genome sequencing and the similar antimicrobial resistance. It was really that shared endoscope that was the logical linkage. When we looked at, we were aware that the FDA had done this sampling and culturing study quite a while ago, in which they, pointed out the issue with the duodenoscopes, and they found that in those processing of those scopes, there was about a 1.1% failure rate with high concerning organisms. So just indicating there's some inherent risk of infection in the processing of these scopes, generally. So specifically, we just wanted people to consider that gastroscopes needed to be also considered a source of contamination, and that other facilities needed to validate their existing practices. And really, more studies need to be done just to assess and decrease that risk of contamination. So that's my summary.
Thank you, Jim.
Yeah, you're welcome.
And then up next, we have Tamika.
Okay. Hello, everyone. I'm going to describe an outbreak investigation of Staphylococcus scalded skin syndrome in the neonatal intensive care unit using whole genome sequencing. So just to give a quick overview, Staphylococcus scalded skin syndrome is also known as Ritter's disease. It's a blistering skin condition caused by Staphylococcus aureus. It usually occurs in infants and young children under the age of 6. The main symptom of scalded skin syndrome is blister formation on the skin, which is caused by exfoliative toxins produced by Staph aureus. The toxins can lead to a range of illness from localized blisters to severe exfoliation. This condition also carries a significant mortality rate among neonates with secondary complications. Next slide. So these are just some examples of the skin peeling and the rash associated with SSSS. Next slide. So on February 18, 2023, a 7-day-old infant was admitted from home via St. John ED to the NICU with sepsis and peeling rash. The infant expired on February 19th. Methicillin susceptible Staph aureus was isolated both from blood and wound cultures from the skin. The patient was noted to have peeling skin in the lower abdomen, scalp, fingernails, and toenails, along with erythema at the extremities. The patient was diagnosed with SSSS, and this was a very severe case of scalded skin syndrome. The nurse that took care of the patient noted that the patient's fingernails and toenails were completely gone and the scalp was completely peeled. So case number 2, on March the 3rd, a second patient was identified with having SSSS. The patient was admitted on February the 21st and shared the same room, was admitted to the same room as the previous SSS case. And this was our first case of hospital-acquired SSSS at our facility. Next slide. So this led to a meeting with infectious disease, infection prevention, and a clinical team in the unit. The decision was made to conduct baseline point prevalence testing of Staph aureus in the NICU. We also scheduled a planned meeting with the Michigan Department of Health and Human Services and Ascension Infection Control leadership. So case number 3, the patient was admitted on February 3rd, 2023, and tested positive during the first point prevalence screening on March the 13th. The patient was placed on contact precautions and received nasal mupirocin. On March the 16th, 2023, the patient developed skin lesions suspicious for SSSS, and this became our second case of hospital-acquired SSSS. Next slide. So a point prevalence screening was performed between March the 13th, 2023 and May 8th of 2023. The screening was performed weekly and on admission. Swabs were collected from the anterior nares in the majority of the cases. Isolates with the same antibiogram were sent out for whole genome sequencing. Screening was performed until no new MSSA case was identified until no new MSS case with identical antibiogram was identified. Infection prevention collaboration conference calls were held weekly to evaluate the effectiveness of infection control measures. Next slide. So 261 patients were screened for Staph aureus. 20 patients, which is about 7.7%, tested positive for MSSA. 3 patients, including the index patients, were identified as having SSSS. Whole genome sequencing was performed on 21 patients. 11 known sequence types were detected. And looking at figure 1, you can see the decline of positive cases after we started our infection controls measures the week of March the 15th. And some of these measures include hand hygiene education, the addition of APIC-GL on the unit, nail picks, nail scrubs, and a mandatory 3-minute scrub upon entering the unit. And also looking at figure 2, the middle cluster that says patient 1, patient 2, and patient 3, those are the patients that were identified as having SSSS, and this shows that they shared the same gene. Next slide. So in conclusion, there was evidence of transmission of SSSS in the NICU. We suspect that it was our supply cart located in the patient room that wasn't cleaned or disposed of in between patients. Infection control measures to prevent transmission included environmental cleaning, hand hygiene, avoiding overcrowding, and isolation of positive patients, in addition to decolonization with nasal mupirocin and chlorhexidine bath per gestation age. Whole genome sequencing analysis are invaluable tools for epidemiological investigation. And when applying to surveillance and investigation in a clinical setting, this approach may provide measures for appropriate and effective interventions. And that is all that I have. These are my references. Thank you.
Great job, Tamika. Hi, everyone. My name is Alex Wells, and I will be presenting my poster on 2 years of zero harm, a multifaceted approach for achieving 2 years without a CAUTI. And I would be remiss if I did not mention the others that were integral with this work. So shout out to Sarah Pracius, who's also on this call, one of our nurses, Tatiana Asanova, and then our medical director, Dr. Tricia Stein. Next slide, please. So just for some background, our facility is a 191-bed acute care hospital in Metro Detroit. I bet you can't guess which system we're a part of from the bottom of the slide. But something significant about our facility is that we are in the middle of many nursing homes and skilled nursing facilities. So our patient population tends to be older. In 2019 and 2020, we saw that CAUTIs were on the rise despite weekly device audits and indwelling urinary catheter indication review. So I have our data for 2019 and 2020. And our standardized infection ratios were 0.69 and 0.6 respectively. And we realized that is still below 1, but we saw that we did not really have a handle on our number of CAUTIs since the number is increasing from year to year. And our clinical team members were encouraged to use external urine collection devices when possible, but available options had varying patient and caregiver satisfaction, so sometimes led to not being used or perhaps even misuse. Next slide, please. So our objectives with this project were to reduce the number of CAUTIs in a sustainable manner, and then to provide appropriate alternatives to indwelling urinary catheters. Oh, back up just one, please. Okay, perfect. So we had 4 major interventions that led to the success of our project. So first was an addition in our electronic medical record in the spring of 2021, and this was a Henry Ford system-wide initiative. So a urine culture hard stop was instituted for patients that had indwelling urinary catheters in place for greater than 2 hospital days. So if a urine culture is ordered on a patient that's been here on an inpatient unit for more than 2 days and has had the catheter for more than 2 days, the EMR will not permit the order. If the patient is showing true clinical signs of having a UTI, or if they have signs of pyelonephritis, our infection control medical director or her designee is able to approve that urine culture to be ordered. But this was implemented to really support pan assessment of the patient rather than going straight to pan culturing. Next slide, please. The next portion of our work was alternative device implementation. So this was in the summer and fall of 2022. So we introduced new condom catheter kits that were an all-inclusive kit that had multiple sizes in the baseline kit. And then we also had a great opportunity to co-lead a trial with our nursing team on a male external urine pouch that hooks up to light suction. And then for both of these products, the manufacturer educators were able to come on site to provide some training and trial support, which was wonderful. Next slide. Our third initiative, education. I feel like we can't have any of our projects without including some sort of education. So our infection prevention team is very involved at our registered nurse and nurse assistant skills fairs and orientations. And some of the CAUTI specific topics that we focused on are aseptic urine specimen collection, and then our IUC maintenance bundles. And then we also have that collaboration with our urine collection device manufacturer educators. So the same people that helped us out with the new products in the trial, they also come typically once a year to do a indwelling urinary catheter assessment, kind of checking on our maintenance bundle and how our team uses indwelling urinary catheters. Next slide, please. And then the last portion, another ongoing thing that we're doing is our weekly indwelling urinary catheter maintenance audits. So we round with unit leaders, either a nurse manager or an educator, and we assess our maintenance bundle. So the seal being intact of the catheter being secured, no dependent loop in the tubing, the drainage bag being below the bladder and off the floor, and then the bag being filled with less than 1,000 cc's of urine. And when we round, our goal really is to fix these findings in real time as much as possible. So that's why we like to round with someone on the unit so that they can reach out to the nurse right away and so that we can fix it right away. Or if we're able to fix it in the room, we'll do that as well. And then we share our data with key stakeholders. So it's our audit information is shared at our infection prevention committee meeting. We share this at our ICU committee with other nurse councils, and we strongly encourage that the leaders are sharing this with their frontline team members as well. And many of them post their data on their quality boards and on the units. Next slide, please. So as a result, I think the graph pretty much speaks for itself. We love to see that decline there. So the total number of CAUTIs and the associated SIR really decreased dramatically with the 2-year and counting sustenance. We are literally a day away from saying that we've had 3 years without a CAUTI. So very excited about that. Hopefully I did not just stick my foot in my mouth by saying that. But through our collaboration among infection prevention, nursing, and supply chain, we have our new male external urine collection devices being stocked in supply rooms through all inpatient, emergency, and observation departments for easy access. So we've got better alternatives, and we're seeing no CAUTIs, which is amazing. So in conclusion and future directions, so we really credit our sustenance of zero CAUTI related harm to the culture of high reliability that we've created with these interventions. And our team members that provide direct care truly are aware of the expectations related to CAUTI prevention. So we plan to continue preventing placement of IUCs if we have another viable option. We have that team education on IUC maintenance expectations, ensuring all urine cultures are ordered when the IUC has been in place for more than 2 days, are reviewed by the infection control medical director for appropriateness. And then of course, the work is never done. So we'll continuously assess our education and supply needs and adjust our CAUTI prevention program as needed. Just a couple of references, and then I do have the poster at the very end, just in case anyone wanted to check that out later. Thank you.
Thanks, Alex. Jenny, you're next. Jenny, can you hear me? Okay, Jenny's microphone isn't working, so we will jump to Christine's presentation and then we'll go back to Jenny.
Hello, everyone. Gonna go ahead and jump right in. My name is Christine. My colleague, my former colleague, Ruben Juarez, he was part of this project with me. He's now over in the state of Minnesota helping them with his awesome EPI-skill. So I want to give props for him and all his hard work. He helped me with this poster. So our poster was titled Reforging Relationships and Infection Prevention Outreach Amid High Facility Staff Attrition, otherwise known as New IP Who Dis. So we're going to go into how this came about. This is just an example of what our poster looked like. And again, I want to thank Ruben again. He did an awesome job with the graphics. I really, really loved how it came together. It was very visual and wanted to draw people in. So this is what our poster looked like. Next slide, please. I just want to briefly go over who we are as the IP unit for people that don't know. We are part of the Michigan Department of Health and Human Services Infection Prevention Unit. We are the IPRAT team, free, consultative, non-regulatory. We provide IPC guidance and support to current care settings throughout the entire state of Michigan. And we have been throughout the entire state of Michigan, which is pretty awesome. And part of our program support is IPC program assessment, staff education, policy review, and infection prevention mentoring. Next slide, please. So what happened is, stemming from our work, when we're providing facility outreach, we have our database that's known as Atlas. And as we're going in there and we're reaching out to these facilities, we're learning in real time when we're calling and we're wanting to speak to, you know, so-and-so we had just talked to a week ago, there's a new voice on the phone saying, oh, so-and-so's not here anymore. This is, you know, this is me. And I don't, who are you? What's IPRAT? What do you mean you were just here and you did an assessment? So basically we would be starting all over again. And the alarm bells raised when we were seeing from our documentation that some facilities were having upwards of 5 IPs turnover since the beginning of the study when we started in 2020, looking through our data. Which was really alarming because we know about instability in the infection preventionist, leads to instability in the infection prevention program, which leads to increased risk for our patients and our residents, and a rise in HIIs and deficits and other practices. So this was really, really concerning. So we wanted to look into this more and see what was going on. Next slide, please. Yeah, that was talking about how we had 5 IPs and some for the head turnover rate. And we know about this, you know, loss of resources, the huge thing is institutional knowledge. I mean, that's gone. It gets wiped out and they start all over again. A huge breakdown in infection prevention practices. And again, like I said, negative health outcomes for our residents and our patients. I want to preface that this study was exclusively done for long-term care facilities. Next slide, please. So our project goals was to better understand the landscape of infection control professionals in our nursing homes. We wanted to know the number of IPs at the facility since January 2020, if there was a handoff process, and who the current infection preventionist was. So what we did is we ended up sending out a survey, and we had questions on that survey that were selected based on the perceived connections that would be considered a stable infection prevention program. Experience and supported IP with facility longevity and institutional knowledge. That's the goal. I mean, when we sent out the survey, we wanted to see what was actually going on out in that landscape. Next slide, please. So for our survey methods, ideally we wanted 1 response per facility from the IP lead. We ended up with our target audience of 55 nursing homes. Our collection period was 2 weeks in November of 2023, and our platform we used Qualtrics. We ended up getting 30 responses. I want to expand this out to all the nursing homes because I would love to see the data we would get from that, but because of time constraints, we had to keep it focused to the 55. We did have a total, we received 43 total responses. However, 11 responses were excluded due to duplicate responses from some facilities, and 2 responses were excluded due to incomplete surveys. Next slide, please. So our survey results, as you can see, we've got a lot of part-time IPs out there, and they are being pulled to the floor. They are also acting as assistant DON. They are also acting as their nurse educator. There is a lot of pulling in all directions. 60% of the infection preventionists are the director of nursing. So they're splitting that role, 2 very, very high demand roles. 30% had no other assigned roles. There was very few that were actually full-time IPs. It was kind of a rarity to stumble upon that. 33% of facilities had greater than 1 person responsible for IP duties. And you notice the years of experience and the breakdown of that. For greater than 5 years, we only had 23% in those facilities. And you see a larger bulk with 1 to 3 years, and then going up to 3 to 5 years, we had 27%. 80% completed CDC or CMS IP education model series and training. And notably, 80% of respondents stated number of IP team roles was actually adequate for their facility, which we were surprised. So that 80% were saying, hey, no, we're good. We have enough. But it was interesting when I go on site, I usually am told a different story, that they're not, they don't feel that they have enough. So it's a little bit concerning when we have a little bit of a disparity there. Next slide, please. Here's just another breakdown. This is talking about the handoff process and how vital this is to support our IPs. coming in, especially in some instances, there would be months, like a months-long gap between the previous IP and the new IP coming in. And with the handoff, 53% conducted a partial review of the infection control risk assessment. 73% reviewed recent surveys and findings with the new IP upon hire. And 57% stated that all areas of concern were outlined within the facility, 30% areas of concern not outlined, and then we had 13% unaware of any areas of concern. And that ties off with, not even having awareness that infection prevention had been, an outside infection prevention consultant had been in to provide assistance and gave them a report. A lot of times that was brand new to them. They had no idea that someone had come in and there had been risks identified and it wasn't disclosed to them. Next slide, please. So in conclusion, almost 40% of IPs in the survey did not have any form of handoff prior to serving as the primary IP. We know how important a handoff process is and how it should be involving ideally the outgoing IP and consist of a full review of the facility's risk assessment, a clear outline of all areas of concern, provide all recent facility surveys, at minimum last 1 week, and sharing of external IPC support contacts, letting them know who's out there, that they're not alone, that they can reach out to the local health department. This is who that is, who their healthcare coalition is, that, IPRAT, SLICS, other programs are out there. So that was where we are at. As I said, I hope if time allows to be able to expand their survey out to all the nursing home facilities and see what the landscape is looking like, though I think we kind of know based on my experience. I'm still calling facilities and I'm still getting brand new IPs new to the facility and still seeing high turnover rates. So just the last slide with our contact information. And that last note that, yeah, they're saying how it's really challenging to be an IP in that setting. So thank you very much.
Thanks, Christine. Jenny, is your mic working?
Yes, can you hear me now?
Yes.
Okay. All right, sorry about the IT issues for me today.
I'm
So
sorry.
I'm going to present to you, that's okay, my poster that was about the role that cleaning and disinfection has in the prevention of an ongoing Candida auris transmission in our surgical intensive care unit. This investigation was conducted along with the people listed on this slide at St. John Hospital in Detroit. And next slide. So as I'm sure everyone on this call is aware, Candida auris is an emerging pathogen, a fungal pathogen that is multi-drug resistant, and it can be easily spread amongst hospitalized patients or patients in long-term care facilities and can survive on hospital surfaces for over 2 weeks. Our investigation started when we received a call from the lab that one of our patients had Candida auris in the blood, and that was about 2 years ago on November 20th, 2022. And next slide. So I'm just going to walk you through our investigation. So we had the first case, which was the Candida auris in the blood. The patient was cultured on the 17th, but we received the call on the 20th. The next day, right away, we placed that patient into contact precautions. We made sure to stress the importance of hand hygiene, also the appropriate cleaning of the room using an EPA List P product. The next day, however, we received a call from public health that there was another patient who was now at a different facility. They had been performing surveillance screening on their patients coming in. That patient tested positive for Candida auris. That patient had a link to one of our intensive care unit rooms. So now we had 2 patients. One was in our medical intensive care unit, one was in our surgical intensive care unit, and one was a colonized specimen, one was an infection. We partnered with our friends at the Michigan Department of Health and Human Services, and we came up with a plan that we would begin point prevalence screening. So we performed our first PPS on November 29th, and that consisted of 15 patients that were screened. And once we received those results, we had an additional 2 positive cases. One of those cases was now in our one was in our cardiac intensive care unit, and one was in our surgical intensive care unit. So we have patients now in 3 of our different links to 3 of our different intensive care units. However, in our surgical intensive care unit, the patient that was part of the point prevalence screening in that first point prevalence screening and the case that we were called about from public health were noted to be in the same room. We then went and tested the current patient in that room, in SICU room X, and that patient also was positive for Candida auris. Right at that same time, we did a second point prevalence screening, which consisted of 24 additional patients. And all of our point prevalence screening patients were patients that had some connection to Candida auris case. So either they were in the room of a previous positive case, were in the room next to them, or had some link to a positive known case. From that second point prevalence screening, we had 1 positive case, and that case again was linked to that same surgical intensive care unit, room X. At that point, we had 4 cases now linked to 1 specific room, and we halted all of the admissions to that room. We did environmental culturing of the area. All of the environmental cultures were negative. During that time, we also went back and looked at all patients who were previously in that room and flagged their charts that if they were readmitted, we would screen them, or we tried to look into seeing if they were in another one of our facilities, if we can screen them. Fortunately, we were able to screen one of those patients that had a connection to that room because they were in a long-term care facility that is actually located within our hospital. Although we do not have jurisdiction through that long-term care facility, we were able to screen that patient. That patient also was positive for Candida auris. We were fortunate in the time that we were able to go back patients before that patient, and those were negative. So we were able to find the initial patient that we believe was patient 0 for having Candida auris. And then from there on, we had 5 consecutive patients, 4 additional patients from that one case 0 linked to SICU room X. We did another point prevalence screening, and all of those patients for the third prevalence screening, which consisted of 21 patients, were negative. We also did another round of environmental cultures, and all of those cultures were negative. We decided to reopen the room on January 4th. And next slide. So during this time, we made sure that we educated all of the staff on proper cleaning and disinfection. And this included nursing staff, anyone involved in the patient's care. So that would include respiratory imaging, anyone who would be working with patients, as well as a focus on environmental services. The guidelines on the left were created for education purposes. That also shows our contact precaution sign. And then we eventually created a flag for the patient's door. And now everyone knows that an orange triangle indicates a patient who has Candida auris or is being ruled out for Candida auris. We made sure that we were disinfecting using EPA List P disinfectants. And we also had the use of an electrostatic sprayer. So EVS had an electrostatic sprayer that they were used in the patient rooms and anywhere else that we felt may have been contaminated. We also made sure that all the cubicle curtains were changed upon discharge. One of the big things I wanted to note was that we had carts within all of our ICU rooms that contained drawers full of supplies. You can see pictures of some of the drawers that had numerous amounts of supplies in them. We really think that this was what was probably leading to our transmission. So even though the rooms were being cleaned appropriately, if healthcare workers were accessing these drawers with dirty hands, then the supplies were getting dirty, and even the electrostatic sprayer was not able to reach the contaminated supplies. So we did make sure that anytime a patient with Candida auris is in one of these rooms, all supplies need to be discarded once the patient is discharged or is transferred to a new room. And next slide. And if you have any questions, feel free to contact me and I can answer further questions. Thank you.
Thanks so much, Jenny. And then I will hand it over to Denise to do questions.
Thank you so much to all of those presentations. They were fabulous, very engaging and very interesting subjects. Thank you. I have a question for Tamika, if Tamika is still on. The question for Tamika is, you discussed a primary focus on hand hygiene improvements, knowing how complex isolates are to clean and disinfect, sometimes 30+ steps. Were there ever suspected to be another potential reservoir? And then the second question is, any improvements identified in the cleaning and disinfection of these devices?
Way of recording the isolates that the actual patients are placed in, and from patient, the index patient, and then the second case, and then the third case, they all were in different isolates. So we didn't feel like that was a means of transmission in the unit. And what was the second question?
The second question was, any improvements identified in the cleaning and disinfection of these devices? And I need you to talk just a little bit louder. You're a little on the quiet side.
I'm sorry, can you hear me? Can you hear me now?
Much better.
Okay. So any improvement in the disinfecting of the equipment?
Yes.
So one of the things when we had the health department come out into the unit, we were actually cleaning our isolates in our dirty utility room. So the recommendation for that was to actually find a different area to clean our isolates. And if you're kind of like us, we are strapped for room in our unit. So what we did was actually have one dedicated room to where we would clean the isolates, and we recorded everything from the time it came in there, the disinfected, the person who cleaned it. And then afterwards, we also incorporated ATP testing on the unit, and the isolates previously was not included in that ATP testing. And so every month, along with ATP testing of other areas in the unit, we included those isolates as well.
Thank you very much. Dorine was also asked, is there somewhere we can get a copy of the air quality risk assessment? She did share the email of the person. It is jennifer.ormsby, ORMSBY, @childrens.harvard.edu. So if you're interested, you can reach out to her. She was one of the creators of that risk assessment. And that is it for questions. Thank you so much. Upcoming events, please register for our October 10th APIC Great Lakes Fall Conference. Our theme this year is You Have Friends in IP. We have a list of great speakers, and we also have a couple interactive sessions. So you'll be able to get up, move around periodically to be able to really enjoy the day and network with your fellow IPs. Next slide, please. This session will be has been recorded, and we are going to be putting it up on the YouTube channel. It usually takes 2 to 3 days for us to be able to get it up there, and so keep an eye out for an email from our chapter secretary. She will send out the link and let you know when it has all been uploaded. Next slide, please. If you have an open position, we'd love to hear about it. Please reach out to us about job postings. You can reach out to the webmaster, Rebecca Batches, at apicgreatlakes@gmail.com. Next slide, please. And finally, I want to say thank you so much for joining us today. We really appreciate it. And please don't hang up. I am going to stop recording, and then Jenny and Dorine are going to start the session of the mentoring IPs as soon as, there we go.